And good afternoon, everybody, and welcome to our special edition of the CPE Speaker Series, one that is specifically focused on our faculty and, in particular, our instructors. We're very honored to have the opportunity today to hear from William Chung, Senior Vice President from Shoppers Drug Mart. I am going to turn it over to Annalise now to do a formal introduction of William, and I look forward to a really interesting and interactive session with everybody. Annalise.
Thanks so much, Subin, and welcome to William. Thank you for joining us today. So our CPE Speaker Series session is going to take a little bit of a different format. We're going to have a presentation by William, and then we'll just open it up to our audience online for question and answer. So please feel free to type any questions you have into the chat box at any time, and then I'll moderate them after William's presentation. So as Zubin mentioned, our presenter today is William Chung from Shoppers Drug Mart. William is the Senior Vice President of Care Partnerships and Business Development at Shoppers Drug Mart. He's responsible for financial planning and analysis, retail pricing of prescription drugs, financial performance for both public and private payers, as well as mergers and acquisitions for Shoppers Drug Mart and Loblaw pharmacies. For the past 31 years, William has been involved in driving growth, development, and performance of health, life science, and retail companies, including Rexall Pharmaplus, Jean Coutu, and MDS Inc. At these companies, he's held progressively senior management positions in operations, corporate development, mergers and acquisitions, and strategy. William has a Bachelor's of Science in Pharmacy, a Master's of Business Administration, and holds a Chartered Business Valuator designation. So today, William will be speaking to us about how megatrends in pharmacy are affecting professional practice, influencing direct patient care, and highlighting the importance of pharmacy in the healthcare ecosystem. In this session, he aims to explore the role of digital technology in pharmacy to demonstrate the evolution of pharmacy as the epicenter of community care, and to share perspectives on how key healthcare policies such as Pharmacare could fundamentally affect the practice of pharmacy. So please join me in welcoming William, and I'll pass it over to you now.
Annalise, thank you so much. Everybody can hear me okay? Thumbs up, we're okay, fantastic, that's great. Zubin, thank you again for the invite. I was looking forward to do this in person, but we'll actually have to do it virtually. But it was really an honor to be invited. And what I want to do this afternoon is just to share a few things. And I'm trying to make sure that of the content that we covered, how can we shape it in such a way that there is a little bit of structure around thematically anyways, on what we're going to be speaking about. So I have tried to kind of categorize it in three areas. The first is really looking at how digital health has evolved and specifically its applications in the pharmacy area. The second area that I'm very passionate about is that, I would like to see pharmacy as being the epicenter of community care. And I think we've done a lot as a profession in order to move that way. But I would argue that there's still a lot for us to continue to do. And lastly, I'll share a little bit of perspective around healthcare policy in terms of how it affects our profession. That is a very heavy topic, so I will try to really touch on really one key issue, that being Pharmacare, that I believe is pivotal for us as a profession to solve, and it has significant implications for the Canadian healthcare system at large. So with that, let me kind of jump right in to the first area. And when we're talking about digital health and we're talking about pharmacy, it's all around technologies. And I think technologies have a pivotal role in terms of enabling pharmacy practice. And, in this particular area, I wanted to maybe shape the discussion by using 4 subtopics, and that being data interoperability, how cloud platforms have really affected our clinical practice and continuing to do so. Predictive analytics and AI, there's no discussions today of any sort are short without touching on AI as a topic. And then lastly, around virtual health. So maybe let's kind of jump into these. Well, I remember, when 30 years ago, when I started community practice as a young lad behind a prescription counter, I would have never thought that today, particularly in the wake of COVID that so many of the digital technologies that we have been really accelerated. And that's a key theme that I want to draw upon this afternoon. So if you look at our prescription dispensing system, and a lot of you know this, when some of you may have been working in retail in the past, you will know that it is primarily what I've been calling a transactional engine. It's used to process prescriptions. And I think what has been the Achilles heel of all of these dispensary systems is that they lack the ability for us to track longitudinally health outcomes. But that is changing, okay? And that's changing because today, in order for us to care for our patients, it has to evolve to really a health record for the patient and not simply a drug record. So in other words, our dispensary system today have to not hold prescription information, but it has to hold past medical histories. It has to hold immunization history, a lot more important now in the wake of COVID as we enter into immunization for COVID upcoming this year. And the pharmacist should be able to communicate to the patient really anywhere, right? Not only by phone, not only by email, but by text. And if you think about it, a lot of the appointments and a lot of the interaction that we have with our patients is migrating towards a virtual type of landscape. And that means the ability for us to perhaps schedule an appointment, to schedule that diabetes mess check with our patients become vitally important as we move forward. And this type of digital health platform, this personal record, has to obviously have health information for the patient at their fingertips. But more importantly, and this is another one of those resounding themes that you hear from me, we need to do a much better job as a profession of tracking the health outcomes. And as I've always said to my colleagues, it's not the number of Met reviews that we do, it's not the number of flu shots that we administer to our patients, but how has pharmacists affected the health outcomes of our patients? How have we been able to decrease morbidity and mortality? That's where the profession needs to take a stronger stance and have us be more accountable and move towards that. And I think you will begin to see that more and more. It is really difficult to change human behavior, to change our patients' behavior, and we're becoming using different types of gamification, different types of loyalty and rewards programs to see if we can make a difference in terms of incenting the patients to achieve their own healthcare goals. I mentioned earlier that there are a number of technologies that have been accelerated in the wake of COVID, and definitely virtual care is another one of these. So this is the latest data from CaiHi, which was just released a couple of months ago, and it shows that prior to really the COVID timeframe of last year, that face-to-face interactions of family physicians in Ontario were predominantly all done with the patient in the physician office. And fast forward, in terms of what happened in the wake of COVID, you will see in the yellow bars, that's hashed, that more and more of these visits have become virtual now. Actually, about 50% have become virtual. And that's a statistic that, to our knowledge, that have lasted, that have continued on. Important to note that overall, the number of visits, the number of activities that family physicians have seen compared during the COVID timeframe of last year, right, in and around the February to June timeframe was still less than what the interactions has been versus a year ago. That is a very important fact. I'm going to come back to this a little bit later on and show you what the issues are. And so absolutely, more and more patients are using digital virtual health to look at resolving minor type of interactions. And this is a platform that's from Maple that you can go in and get a consult. And this particular patient seems to have an issue with UTI. They can see a physician, in this case, Dr. Palmer, right? And within minutes, you're connected with the physician, and minutes later on, you're given a prescription for macrobid. That is the practice of medicine today, at least for 50% of the interactions that we see. And by the way, you can even choose a pharmacy and have this prescription perhaps electronically written, right, across and shared with the pharmacist so that you don't have to wait in line when you go in to pick up the prescription. That is the macrobid prescription that you see on the page. I'm not sure if you can read it, but I sure can't. And that is an issue for us in pharmacy, in that particularly in Canada, 5 out of 10 prescriptions are still handwritten. And when I say the other 5 are electronically written, it is not electronically prescribed per se, right? There's a fundamental difference. And it's an issue in pharmacy because I think we can do a lot more in terms of medication safety if we have what I call data interoperability. I know that's a hard word to pronounce, but that means having systems to be able to talk to one another. And it is important because I think that's an area that in Canada, we're way, way behind other jurisdictions. And if you look across Canada, yes, we have made significant progress in terms of electronic prescribing, but we can do a lot more in terms of helping our patients get the right medications, helping pharmacy get those medications dispensed in a very efficient manner if electronic prescribing was throughout Canada. And in fact, if you compare Canada to our partner south of the border, the US has done significant in terms of investments, in terms of regulations around e-prescribing. Around 80% of prescriptions in the US are actually e-prescribed, compared to less than 1% in Canada. And a full e-prescribing platform, that means the physicians are writing on an electronic medical record, and that record is not transcribed, is electronically, right, wired to the pharmacy's terminal, whereby we eliminate a lot of the interpretation and transcribing issues that we have in pharmacy, particularly community pharmacy. And I know that in the hospital area, we have advanced quite a bit, but community is definitely lagging. So we need to do a much better job as an industry to push e-prescribing, because I think it does a lot to improve the safety of medication dispensing for our patients. And like I said before, no talk would be complete without AI. And you're wondering, well, you know, why would AI matter? How could AI make a difference in the practice of pharmacy? And I was introduced to this firm a little while ago, and essentially Triage Health, and they're based in Canada, can use your smartphone, right? Take a picture of any mole, any acne, any skin condition, and in fact, 500 of these skin conditions, and could tell you within seconds of what that skin condition is, okay? And so put aside whether there are any, you know, randomized clinical control trials that have documented this, but this is the power that's in the physician's hand right now. So if you imagine one day in Ontario, if we're able to do minor assessments just like our colleagues in Alberta, and be able to write that prescription for a minor ailment, how powerful would it be for our pharmacists to have AI tools like this that could diagnose atopic dermatitis, that could diagnose an acne, that could know whether a mole is malignant or not, right? So to help pharmacists make better use of our skill set, coupled with technology, I think is really the pharmacy practice of tomorrow. So the second topic I'm going to cover off is how pharmacies then can be the epicenter of community care in Canada. And if you look at the practice of pharmacy today versus back in 2005, just 5-6 years ago, and don't try to read all of this. This is from CPHA, and I just wanted to maybe for you to get an impression, get an understanding that, first of all, the scope of practice has increased significantly across all of the provinces. And in fact, I would argue that there is a lot more that we can do. What you should take away from this image is the patchwork of activity that we have in Canada, that no two provinces are alike. And, you know, for our poor patients that are living in Nunavut and Northwest Territories, you can see a whole bunch of excess because unfortunately, pharmacists cannot do a lot in those provinces. But for the pharmacists that can give a flu shots to our patients, for the pharmacists that can administer a med review over the screen, for the pharmacists that can administer and conduct a hemoglobin A1C test, for those of us who can do a travel consult. And most recently, you will see that lots and lots of pharmacists have been involved in COVID testing. And I guess if you ask me when I graduated from U of T 30 years ago, I think in my practical labs, I was, you know, injecting an orange back then, right to practice. But, you know, we weren't necessarily doing a lot of the point of care tests that you see in front of you. And we definitely back then were not doing diagnostic procedures such as COVID testing, right? And I think it's fantastic for a profession to step up, but there's a lot more that I think that we can do. I've shown you some statistics earlier in terms of what scope of practice is in some of the province. And no talk will be complete if we don't touch on COVID. And during the COVID timeframe, now this is a very complicated diagram, so I'm going to explain this to you. During the COVID timeframe, you would know that a lot of the patients have had issues with access to physicians. So what we did was that we worked with IQVIA and we said, gosh, so many of our patients are not able to do a virtual care because they can't afford it, right? They can't afford that $50 that Maple charges. So I'm wondering if there are actually issues with the latency period between when patients are seen and the continued backlog of patients that likely was to start on new therapy, but because of COVID, they have not. So through a lot of analytics, we're able to see that, yeah, during the normal course, you can see in the blue line before the COVID timeframe, that there's a steady diagnosis of new conditions for our patients. But when COVID hit, because of the lack of access, and because in a lot of the provinces, we as pharmacists could not make minor ailment diagnoses, a lot of our patients, I would argue, are underserved. And the green line that you see are the cumulative backlog of Canadians. And this data, right, was only until September. And even back in September, it did not really curb in terms of that demand. So I think there's a lot more we can do as a profession. There's a lot more advocacy that we can do to convince our regulatory bodies, our colleges, to make sure that we were trained on assessment, we were trained on minor diagnoses, and allow us really to practice at our full scope. Because if you look at the key determinants of health during COVID, a lot of patient care, I would argue, were compromised, right? And it's because we can't really help them in the full extent when we're behind the counter, particularly in the retail community setting. So there's a lot more that we can do for immunization. There's a lot more that we can do for mental health, right? Which is a condition that, particularly during COVID, that we know a lot of Canadians are suffering from, because we are all social animals and we weren't meant to be staying at home, right, for this long a period of time. So yes, we have done lots and lots as a profession in terms of driving prescribing, again, particularly in provinces that have the scope, and even in Ontario, that we can do prescribing in smoking cessation, I think is a step forward. And you can see that the good thing is that compared to other professions, such as, for example, our nurse practitioners or optometrists, we as a profession have moved the needle in terms of assessments and prescribing. And I think this is the future of pharmacy. And if you talk to a lot of our colleagues, particularly in Alberta, you will know that they are particularly enthusiastic in terms of the scope that they have. And again, my urge and our advocacy efforts really as a profession is to make sure that we have this equity across all of Canada. I talked about technology a little bit earlier, but to really put the two themes together, we can really only operate at full scope and help our patients and increase the one-on-one patient care, whether that be virtually or whether that be in person, if we're not doing so many of the manual tasks that we are. Particularly I can speak of in the community pharmacy setting, where a lot of these are still done by just hard manual labor, right? You think about order entry, right? And what is order entry? Order entry is interpreting, is transcribing that prescription and putting it into a fill and bill system. Why can't we use e-prescribing to accelerate it, to increase the efficiency, to increase the safety of our patients, right? You talk about prescription fulfillment. We're using robotics in our store to make sure that for those high velocity medications, we put it into a robotic central fill, perhaps, but some of the robotics that are in store to make sure that we eliminate as much of those tasks as possible for manual filling of prescriptions and make sure that we increase the efficiency and increase the accuracy of the fill so that we can spend more time with our patients. And a lot of these, and I'm not going to go through this entire list, but a lot of these technologies are available today. They aren't available to every single community pharmacy because there's a cost, right? And you have to have certain volumes in order for you to put these in. But I think these are some of the barriers that we have identified. And in many, many cases, that's what we're doing to make sure that we can free up valuable time. I often still think that no matter what robotics, no matter what virtual care, no matter what AI you have, but patients are sticky to their pharmacists, particularly in the community setting for a reason. It's because of that personal relationship. And I don't believe that you can get that personal relationship with an AI program. So just to finish up then on our little chat this afternoon, the whole healthcare policy area, gosh, I could probably spend several hours on it, and it gets to be quite dry, actually. But there are a couple of files that I've been looking after that I'm particularly passionate about and close to. But a lot of the health reform files, and I'm only going to talk to one of them, which is National Pharmacare this afternoon. The other file I handle is the PMBRB pricing negotiations. Well, no longer negotiations now because the price has been set. I won't get into this afternoon, but really what COVID did was change the agenda and perhaps paused, right? Not rewind, not totally stop what has happened in healthcare reform. Paused. And a lot of new priorities have taken over, right? The priorities around mental health, the priorities around long-term care and home care, for our patients to age gracefully at home, OR time, right? And obviously, not so much flu vaccination, but more prominently, COVID vaccination. And that narrative has changed, and it has changed on healthcare reform, particularly because of the fiscal backdrops that we have seen, both in terms of on a federal level and also on a provincial level, right? It's been very significant in terms of what the governments have done on investments, right? on economic stimulation to get the economy going over again. But if you rewind back a number of months ago, the front and center issue was really Pharmacare. It is the most significant public policy that I would argue that we have that's facing Canadians. And if you read the Hoskins report, and if you've read in terms of what Pharmacare was meant to do, you would know that the idea was for a single payer system for all Canadians, a significant investment, right, from Canada in order to do that. And you will know that by in and around the 2027 timeframe, a comprehensive national formulary will be rolled out. But before then, the Canadian Drug Agency would be formed next year. They would look at putting together an essential medicine list for Canadians. A lot of policies need to happen between that timeframe, and for us to really focus on what a really rare disease strategy drug is around that timeframe as well, and hopefully ending by 2027, really on a national Pharmacare program. But if you look at the prescription coverage for Canadians today, there are actually very few Canadians that actually doesn't have drug coverage. There's only about 600,000. And I know that you've been hearing a lot of figures, so I'm going to try to explain this in a very simplistic manner. That if you look at Canadians today, actually around 35.5 million Canadians could have access to drug coverage. A bunch of those have access to private, and a few have access to public, primarily the seniors. However, there are about 3.6 million Canadians, or about 10% of our population, that are eligible for drug coverage, but they don't know how to access it. It is too confusing. They don't know how to fill in the forms. And I think this is something that we can do a lot better job of. Because if we're able to get these 3.6 million Canadians who are eligible for drug coverage who are not getting it right now, the true problem that we're trying to solve is probably around 600,000 Canadians, right? So if you look at then what we need to do from a policy perspective to solve for Pharmacare, it's fundamentally these four questions. Who should be covered? Should we cover for a specific population or everybody? If you're trying to solve the world, it's very expensive to do so. What drugs should be covered? And obviously, the fewer drugs you cover, the better, but that's not probably the right approach as well. There's got to be a happy medium. Who's paying for drug coverage today? We have a mixed payer system in Canada for both private and public. A lot of you who are working for the university have private coverage today. I work for Loblaw, so I have private coverage today. In a single payer system, it's the government who's the payer, and you will have one drug coverage, but we would argue that you still probably need supplementary coverage because depending on how comprehensive that formulary is, you may or may not meet the needs of a lot of the patients out there, particularly patients with specialty medications, right? And then the last question is, how are costs going to be covered? If all of the costs are covered by government and there's no copay system in place, then that's very expensive for the government versus if there are what we call cost sharing and copay systems. So we don't have time today, but there's another talk, if you want to call it, there's another session that I host for a lot of the payers out there and for a lot of the governments that we try to educate in terms of, if you try to break Pharmacare down into each one of these four topics, there are lots and lots of content that we can share to really shape the discussion. Because as an industry, we do believe that Pharmacare is the right thing to do, that no single Canadian should be without drug coverage. So what we have been advocating for as a community pharmacy is that we need to complete the plan for Canadians. So what does that mean? That means that we need to ensure that every single Canadian has access to medication. We need to make sure that those who have a plan that are very happy with it, perhaps keep their plan and look at ways to supplement. We have to make sure, particularly we as pharmacists, we have the skills and knowledge to do so, to make sure we optimize the use of medications to look at cost effective, not the cheapest, cost-effective medication, right? And we have to do it in a way that's, fiduciary responsibility for the Canadian public is to make sure that we keep costs in a manner so that the plans that it's sustainable, right, for the government. So that is the narrative that from a community pharmacy perspective that we have been sharing for the last number of years on National Pharmacare. So just to end then, so here are the key takeaways. I think technology and digital pharmacy and digital health has tremendous ability to really enable pharmacists to practice at their full scope, to increase the access of care for our patients, to really optimize drug therapy and drug delivery. And most importantly, we can do a lot better in terms of improving the health outcomes of our patients. I think pharmacies and pharmacists are really the epicenter of Canadian healthcare. We should be proud as a profession. We've made a lot of progress in the last number of years, but I would argue that we can make a lot more progress in terms of expanding scope to have that equity, right, for every single province. And I think we as pharmacists who are working in the healthcare profession needs to make sure that we influence the right decision for Pharmacare policy, because it is the single most important public policy that will affect Canadians. And we need to make sure that Canadians have access to the right medication, high quality medication, that we keep innovation and R&D in Canada, hopefully, right? We continue to look for innovative medicines to bring to the Canadian public, and we need to do so really in a sustainable manner. So I know that was very quick, and I know that was a lot of content to share, but I wanted to make sure that we have enough time to really open it up for questions. And with that, I am going to probably go back here. And maybe Annalise, I will stop sharing because you can put out my email and my email address and my phone number to anybody really that wants to have a follow-up discussion. But I'm hoping that this is a little stimulating, perhaps maybe a little bit controversial, but love to get some feedback in terms of how folks are feeling on the phone here.
Thank you so much, William. That's absolutely fantastic. I really appreciated that presentation. I think you went through a lot of the material in a really succinct but understandable way, even with some of the graphs and charts you presented. So I'd like to say thank you on behalf of everyone. I can see that we have a number of people online. So if you do have questions, please feel free to put them into the chat box and I will get to them on first come, first serve basis. Just to start off, we have kind of a comment, but I think this can also tie into a question and a bit of dialogue from Marie. Yeah. She says there's a great deal of concern emerging about fragmentation of care and records with private third-party platforms, so like Maple, like you presented, versus virtual care provided through primary care providers. So I think that's a great point. I'd be curious your thoughts on that, and then might have a follow-up.
Yeah. So, what ideally we should be doing is put together one singular health record for all Canadians. I think this was perhaps the goal of eHealth, of Canada Health Infoway way back, right? It is not an easy task to do. Now, Canada Health Infoway has been, repurposed themselves, right, in terms of their goal into now e-prescribing and tackling perhaps a smaller component of that platform. But it is a great comment, and I couldn't agree with you more. I would like to see one electronic health record for all Canadians that all primary healthcare could populate into, right? So each of the healthcare practitioners, whether it be nursing, whether it be pharmacy, or whether it be physicians, could operate their own platforms to interact with patients, but we should always be uploading information to something that's common. So, in BC, we have Pharmacare, in Alberta, we have Netcare, and so on. But in Ontario, we have nothing, right? So it is very fragmented. There are a number of e-prescribing platforms out there, and there are a number of electronic medical record vendors out there, but to be honest, pharmacies don't talk to them, right? Like we're not integrated, and that's the major issue I have. That when a patient comes in, I actually don't know their diagnoses, right? I see what's on their prescription, but it's very hard for me to understand, is this congestive heart failure, or is this hypertension, or is this, they're using it to control rhythm, right? And often so we are, we lack that complete profile of the patient. And I think that's part of the Achilles heel that we have, in Canada.
Yeah, I think that's a great point. I can see Marie says the elusive EHR in Ontario, which
Oh, yeah.
is a very good point. And then hope that Shoppers Drug Mart and OPA will continue to lobby for interoperability with vendors and government.
For sure.
I think is a key point. I'd be curious, I can see Zubin has a question, but just to follow up on kind of the increasing use of platforms like Maple or Babylon or Dialogue Health, be curious to get your thoughts. Because it's such an isolated time, I feel like people that I even know are turning to those kinds of platforms, which they might find through a Google search or through marketing that they see on the streets even. And I'd be curious your thoughts about just how we can increase public understanding and awareness that these systems are actually very siloed, and that Correct. There is very poor connectivity between them.
Correct. Yeah, it's a great point, and I don't know if the public is aware of really how they operate, right? And the way that I try to explain it is that think of it as a walk-in clinic on a cloud, right? And you think about it that way. You go to an MCI or you go to an Apple Tree, right? These are the two common ones in terms of physical bricks and mortar shops that are in Ontario. When you go in for a sore throat, now they are supposed to electronically or fax that record to your family physician, but I don't know if they do. And to be honest, I don't know if Maple or Babylon or any of these CloudMD, I'm not sure if all these platforms do as well, right? I think it's very what I call transactional type of services that they offer, and they often don't have that connectivity, whichever way. I don't care if it's a fax, I don't care if it's an email back to the attending physician for that continuity of care. So that's the risk that I see, right? In that they are fulfilling a need. And by the way, if you before COVID, none of them were popular, right? Yeah. Because as Canadians, we're used to not paying for a lot of healthcare. So we're used to going to the walk-in clinic. We're used to lining up and getting a consult with our physician, right? But when the physician offices were closed, that's how a lot of these virtual platforms exploded in terms of volume. I mean, you can see the graph that I put in by Kai-Hi, right? It went from nothing to 50%. Right? So that's 400,000 interactions that has gone to the cloud versus face-to-face, right?
Yeah. No, I think it's a really important consideration. I think COVID has definitely spiked that, and it needs to be on our radar with all of this. Marie, I think, just has a follow-up comment. Regulatory changes allowed payment for virtual care, which was a key enabler in addition to COVID, which is a great point.
Absolutely.
So just circling back to Zubin's comment and question for you a bit earlier on, he says, thank you for a great presentation, of course. And since most of us on this call are educators, what are the 2 or 3 major changes you think we need to make in our curriculum to help our students be ready for the future and present that you've described?
Yeah, that's a great question. So, I would say that, particularly in the area of, if you look at where I think pharmacy is going towards, particularly in community pharmacy, I'll say kind of limited in terms of that scope, is that we were trained a lot on being, back then, and maybe not now, but being book smart, right? That absolutely, we've done a lot in terms of expanding the curriculum to more patient interactions. I would say that if I look at myself right now, this is 30 years ago, and what I wish I had more is more the application right, of that academic curriculum. So that means, and perhaps we're moving significantly towards a case-based approach. I know that, when I did my applied therapeutics course, it was all case-based, which is fantastic. But giving, our students real life situations, right? Giving them beyond the practicum period in terms of what they're seeing in the pharmacy, perhaps. So increasing that part of the curriculum will be important. I would say making sure that our pharmacists are coming out to community, if that's the setting that you're choosing, to make sure that they actually are not only good on the hard skills of being a pharmacist, but on the soft skills, right? On how to be compassionate. How do you, allow information to free flow from patients, right? Rather than digging it out of them. And some of the younger pharmacists that I've met still would need a lot more, face time with the patient in order for them to be comfortable, right? And look, I don't know in terms of really our practice, what the true scope limitations will be. Like I said, I never would have thought that we would be doing point of care testing, right? I never thought that we would be looking at diagnostic procedures and taking a nasal swab, right? And in Alberta, I don't know if this is out yet in public, but we actually got the scope changed to a nasopharyngeal swab now that Alberta pharmacists could take, right? So if we could introduce some of these more, I'll call it perhaps leading edge, whether it be technology or whether it be procedures that students might one day do, right? I think it's something that's, a move forward in the right direction.
No, I think that's a great point. We have a question from Lisa, and two questions from Lisa next. I'll start with the first one, maybe, which is, can you comment on the inclusion of professional pharmacist services within Pharmacare?
Yeah, that's another great question. It hasn't come up in a lot of the advocacy discussions that we've had. And by the way, that's kind of twofold, right? When we're talking about pharmacy services, it's always the enablement from our college, right? And then the second thing is just making sure that pharmacists are remunerated fairly for the time and efforts that they spend, right? Because I think oftentimes, and we're one of our worst enemies in that, gosh, ever since the beginning of time, we have offered a lot of our services for free, like particularly in the community area. And that's why, although our scope allows us to adapt a prescription, to change a dosage form that is not correct because the patient can't swallow it, to perhaps adjust a dose. Those are all things that we can do within our powers, but particularly in the past, we weren't remunerated for that. And because of that, a lot of pharmacists are still very shy in terms of having that conversation with the patient, right? Like, we're one of the few professions that offer so many things out of our goodwill for patients at no cost. And now I think a lot of pharmacists is having a hard time, right, changing that dialogue. And it's exactly the same dialogue that we have in Pharmacare, that how do we begin to look at pharmacy holistically as a whole? And it's not only the physical delivery of that product, but how can we make the patient interaction and the assessment and the ongoing care of that patient part of that reimbursement structure? Because it's kind of fragmented today. It's a product and then a service that you tack on.
That's fantastic. I'll maybe follow up with Lisa's next question and kind of comment. She says the unmet care needs is, i.e. the backlog because of COVID, is going to be one of the biggest challenges to deal with as the situation with COVID improves. And I think your slide on that was very punchy and showing exactly that in quantifiable numbers. So given how much work this will create in the pharmacy space, what do you think we can do to be most effective versus continuing to kind of do work as usual and stick with the status quo?
Yeah, so again, I think it goes back to looking at ways that we, particularly in provinces that do not have the scope today to do minor assessments, right? To make sure that we begin to expand that. We've had a lot of talks with, OCP, a lot of talks with the other provincial colleges, and I wanted to make sure that we continue to advocate that pharmacists are an integral part of the Canadian healthcare ecosystem, right? And you look at what nurse practitioners has done in terms of alleviating some of the backlog that we have, and whether it be the ER, whether that be in primary care. Pharmacists is an underutilized resource, right? We have the education, we have the scope. What we need is the enablement of that scope at a provincial level. And I think if we're able to do that, we could be one of the solutions for our primary care colleagues, that being physicians, to look at. We should be able to diagnose perhaps minor issues associated with a lot of these chronic health conditions, right? And I know that a lot of pharmacists are still maybe reticent in terms of starting a patient on insulin, but we were trained, Annalise, to do that, right? We were trained how to titrate. We were trained how do we, do insulin mixes back then, but now probably it's a premix that we have, right? But certainly I was trained in O school, right? Using a mortar pestle to do compounding, and a lot of these are available today. And so I think we need to do a lot more in terms of that advocacy work to really convince the regulators, to convince our government that we are such an important component and fabric of the Canadian healthcare system, and we pharmacists could do a lot more.
Mm-hmm.
That's how we can help that backlog.
Mm-hmm. Yeah, and I wonder if just the ability to get a COVID test in pharmacies will be a really important part of that. I don't know if I want to call it lobby, but really important part of that discussion.
Well, no, absolutely. You brought up a great point. So you've seen that our organization have been pretty vocal, right? And we've been doing a lot of COVID. We call it COVID testing, but it's not testing. It's actually collection of samples, right? Using an anterior nasal swab. You will see very soon, and in Alberta and in BC, we're doing it already, different types of point of care testing, right? So it could be strep tests. It could be, hemoglobin A1C that we do for diabetes patients. And the reason why that is important from a Canadian healthcare perspective is that, and I use strep tests a lot, we are over prescribing our antibiotics, right? And it's because a lot of physicians perhaps give it just in case until your culture comes back. A lot of patients don't want to wait until the culture comes back. They got a prescription in their hand, they're going to fill it, right? What we're trying to do is to really change the dialogue, which is, well, first of all, maybe you don't need to take time off work to go see your doctor. Why don't you come into the pharmacy? You have a really, red throat. I can't really tell if that is a virus or bacteria. I'm going to do a rapid strep test. Yes, it costs you $15. Yes, you can get it for free. But why take half a day off work to wait in the physician office with a whole bunch of sick people, right? Why don't you just go to the pharmacy and get it done? Within 5 minutes, I'll be able to tell you whether you're okay with a Ricola lozenge, which costs you $3, which is not taking up valuable reimbursement of your employer's health plan, right? And you're saving money on the healthcare system because you're not taking up space in the primary healthcare doc's office on a sore throat, right? Yeah. It bugs me every single time that I get a Moxil script, because 9 out of 10 times I know they don't need it, right? Mm-hmm. And I've been in the trenches, like I know, right? So, and you can see I'm passionate about this because I think this is where pharmacy profession needs to evolve to. We need to make sure that we can make that assessment in a very objective manner. I believe that there is a way for us to use diagnostics in order to help us, right? In selective cases, we need to use it in the right way. In order for us, very similar to the AI example that I gave, right, on rashes, gosh, I don't know, I'm not comfortable with that type. Why don't I just, I think it's atopic dermatitis, right, rather than eczema, but I just don't know. And if tools like this could help us, it just empowers pharmacists to do so much more.
Yeah. Yeah, no, it's a really, really important part of moving the profession forward. I completely agree with you on that. I can see Zoom put in 2 comments, which I think you'll be very interested in knowing about this if you haven't heard already. But basically at the University of Toronto, the Faculty of Pharmacy, we've been for the past couple of years working on developing what Zubin's calling a model pharmacy. So it's officially called the Discovery Pharmacy, and it will really focus on kind of bringing together education, research, and practice innovation, both for our PharmD students, but I think with tendrils reaching out quite far into the community as well. So Zubin has, I think, a question. Any thoughts on what this Discovery Pharmacy should do, look like, be, focus upon in order to be an engine for innovation and really prepare our students for the future? And I think that's the piece that I'd be most interested in as well, of how do we teach students to think to be leaders for the future?
Absolutely. And I would encourage us, and I often don't like to blow the ocean, but my feedback would be that the Discovery Pharmacy should ideally be interdisciplinary. Okay, it should not be a silo pharmacy. I would love to see how we can make this really into a discovery health hub rather than a discovery pharmacy. This health hub should have interdisciplinary practice. It should have a physician. That physician should be on an EMR. That EMR should be talking to the pharmacy. No more written prescriptions, because I can't read that macrobid prescription. It doesn't matter how many times I look at it. It's just not possible, right? I would love to see that the communications that love to hear from patients, but ideally the mode of communication is by email, right? Where we're not interrupted, okay? I would love to make sure that we have more counseling rooms than just one in the majority of pharmacies. And in fact, the pharmacy design that we're putting in a lot of our stores anyway, on community pharmacy, are now at least 2 rooms, if not 3, okay? Because I rather do more pharmacy services than sell toilet paper. Now, I don't know about you, but I can tell you, in community pharmacy, we don't make a lot of margins on toilet paper, okay? But during COVID timeframe, unfortunately, that's kind of the hot sell, right? But I'm trying to convince my front shop colleagues to give me as much toilet paper space as possible, because when we do start the COVID vaccination program, I need to almost have tubes set up in my front shop in order to accommodate the number of patients. I would love to see this Discovery Health Hub be the practice leaders in not only community traditional pharmacy medications, but begin to look at more specialty medications. Community pharmacy is evolving because a lot of the specialty drugs that we have are now given more in solid dosage forms, more IM, more sub-Q than the traditional IV. I'm talking about the Remicades of this world, okay? Yeah. I would love to see how we can be more involved in complex care of that specialty patient, right? Because that is not an area that community pharmacy is active in today, right? I would love to see a hub and spoke model where we have health hubs of excellence across the country, right? And I think if U of T is doing this, count me in. Love to be a thought partner in terms of how we can put the right pieces in place. But lots and lots of ideas, Zubin, in terms of how we can make this really an experiential experience for our graduates to come.
Yeah. Thank you so much. I think we'll definitely take into consideration all of those thoughts. I think you brought up some great ideas for what our pharmacy and health hub could look like. Just transitioning, I know we're coming close to the end of our time, but I think that this is a good opportunity to put in a bit of a plug for our next CPE speaker series as well, which will also be held with Shoppers Drug Mart, focused on their health clinics, the recent launch of some of the health clinic locations. And our discussant for that session, so we'll have a shorter presentation followed by a few remarks from Natalie Crown, who's a professor at the University of Toronto at the Faculty of Pharmacy, and she's been working with myself, Zubin, Lisa, and a few other people to think about some of our specific programs for the Discovery Pharmacy. So more specifically, talking about kind of our immunizations working group, travel health, medicine, that sort of thing. So that will be happening on March 4th. So everyone online and William as well, stay tuned. I think that will be a very interesting session. And then beginning next Wednesday, we also have the launch, for those who haven't heard about it, we have the launch of the Open Summit, which will be held over the month of February. It'll be a half-day session every Wednesday in February, and that will focus on sharing practice, innovation, and research that's happening across Canada in medication management. So all that being said, I think on behalf of everyone online, we'd just like to thank you so much, William. That was a fantastic presentation, really engaging discussion to follow. And on behalf of the faculty, I'd like to thank you.
Oh, you're very welcome. It was a privilege, really.
And let me take a moment to thank you, William, and to thank all of our attendees today. You've certainly given us a lot of food for thought. We really appreciate you taking the time to share your insights, your data, and your vision of where we're going in the future. And hope to see everybody at the Open Summit next week and at future CPE events. Thank you very much, and have a good evening, everybody.